evening and welcome to CURE. I'm Seema Kumar. I'm the Chief Executive Officer of CURE, and I hope you're enjoying this beautiful facility. We were just admiring the views. It's just incredible, isn't it?
Absolutely.
And so CURE, for those of you who don't know, is an innovation campus, and we're newly launched, and our goal is to advance healthcare and to find cures, period. That's why there is a period after our logo, CURE. But it's much more than a building. It's much more than an innovation campus. You know, there are so many people who, give their heart, blood, and soul, every day here in the wet labs all over this building, in offices, in the collaboration residency, to really push the boundaries of healthcare and advance human health. But the other thing is that it goes well beyond this building. It's not just this building, it's the city, it's the ecosystem, it's the whole world, improving healthcare. And speaking of improving healthcare and making an impact, today we have a really special Tuesday talk, and joining us is Dr. Adam Aponte. And he is actually he's a pediatrician, right? And Chief Medical Officer at East Harlem Hospital, Council for Human Services. Mm-hmm. And his many accomplishments are, captured in his bio, but really what struck me about Adam was when he was a 9-year-old, growing up as a kid, he had a big dream, and the dream was to be a doctor. And he saw many medical students pass by his house, and they were going to Mount Sinai School of Medicine, and he was asking them all these tough science questions. Telling them, one day I'm going to go to Mount Sinai, and you did, and you're a role model. You're doing some great work, and we're going to get into that. But I really want to dive into who you are as an individual, the inspiration you are, but also the work that you do, and why that is important, and what your future aspirations are. So with that, I'm going to get right down to it and go to your childhood. So talk to me a little bit about your childhood, your growing up years, and did you ever dream that you would be where you are today?
You mean sitting here with you, Seema?
Yeah.
Never. First of all, let me start by thanking you and CURE and your staff for more than just welcoming us to this space. Really intrigued by what you're doing here, and happy to be a part of these conversations, and really excited to have this dialogue that I have on a daily basis, but to expand this to other people. So East Harlem, New York, parents in Puerto Rico. Where's my Boricuas at? I know there's a couple here. And one of 7 children. I'm number 6 of 7. And as you mentioned, I had this dream from very young, actually even younger than 9, that I would be a physician. And it was interesting because no doctors in my community. Unfortunately, those people in the pharmaceutical industry in our community, you did not want to hang out with. I usually stop and take pause to see how many people actually understood what I just said, but maybe like 3 or 4 of you figured it out. Some of you are starting to catch it now and think about it.
It's clicking.
It's clicking now. But it was something that really struck me based upon a couple of things. And I'll just go through it briefly because I know we don't have a lot of time. But first, love of sciences. I was that kid who loved to watch all the nature shows and just fascinated with the human body and the human brain and all the things that we could do. And if you think about the human brain, for those researchers in the room, we know we haven't even tapped into the full potential, right? So you imagine what we can do if we really fully tap in. So that was always amazing to me. Part of it was what we describe today as health disparities. And certainly I didn't know that term when I was younger. I think that was coined by Dr. David Satcher when he was Surgeon General. But I lived on 97th Street between Park and Madison, right? On the border between East Harlem and the Upper East Side. So I had a bird's eye view of these health disparities that exist between the Upper East Side, right? One of the communities that have the highest concentration of millionaires. And then you cross this double yellow line that we call 96th Street, and now you're in East Harlem, and everything changes. And the striking differences between those communities in terms of crime, drugs, schools, hospitals, and then health conditions really struck me. And I wanted to do something about it because I felt like, why are these two communities so disparate, yet they're literally 100 feet apart? And then finally, if I can say this, is after 5 o'clock, it was kind of my badassness. It was like, I'm going to be a doctor because society says a Puerto Rican kid from East Harlem is not going to be a doctor. and I was going to prove them wrong, even though I wasn't always as certain because there wasn't like society saying, yes, you could do this. There wasn't Puerto Rican doctors on television, but it was something that I wanted to do and sort of really demonstrate. And so that was my path.
So not only did you become a badass doctor, but in addition, you know, many other people, once they graduate and they have the better life, then they move over to the suburbs, and then you're, starting your private practice somewhere else. But you decided to actually go back and serve your community. I mean, why?
Well, that was the dream. That was the purpose. That was the why, right? So why do I want to do this? Because I want to come back into my hood and take care of my people.
Yep.
And for me, I talk about having a lot of gravy on my plate because I just thought I'd be a doctor in the hood, taking care of patients one-on-one. But I was very fortuitous to really, have good mentorships. Actually, one of my mentors is here, Dr. Ray Cornbill, in the audience, who actually encouraged me.
Where is
he's
he?
hiding. Where is Ray? Where'd you go, Ray? There he goes.
There he is.
So Ray Cornbill actually, when I was 3 years out of residency, encouraged me to apply for a job as a chairman for Department of Pediatrics for a community hospital in East Harlem. And I looked at Ray and I said, Ray, you're crazy, right?
Yeah.
I'm 3 years out of residency. There's no way.
Mm.
And what he taught me was that it doesn't matter.
Yeah.
Just go, gain the experience.
Mm-hmm.
It was one of the first time I went to an interview, right, where you had like a whole conference room of people and everyone's throwing questions at you. And it was a phenomenal experience. And just the experience alone, I think Ray was right, was very fulfilling. But you know what happened? I got the job.
Yeah.
And I became the chairman of the Department of Pediatrics at a very young age. I was the youngest chair actually at that time, and I was managing a department. And it was always about coming back into the neighborhood. Definitely had opportunities to go to other private practice, and we're in Park Avenue practices, because Mount Sinai was right there.
Yep.
But to me, it was always being back in the neighborhood. And my career has been about diversity and underserved communities.
So tell me why it's so important to have this sort of, diversity and inclusion. It's now become like a very, trendy term, and everybody's caring about diversity and inclusion. But it's not just about the numbers. There is a real business imperative. There is a, it's not just a moral imperative, but there is also a business imperative to it. Explain that.
Yeah, and I'm glad you led that way, because a lot of people don't understand that diversity is a business imperative. And fundamentally, if you think about, like, for those of you who have stock, first thing your stockbroker tells you is what? Diversify your portfolio, right? You take all your money, you put into Home Depot tanks. By the way, Home Depot is a good investment for me. But it tanks, you lose all your money, right? So you diversify. You put a little bit in stocks, bonds, you put it under your mattress like my parents used to do, right? So you diversify everything you do. And in healthcare, if we want to improve healthcare outcomes, then we have to be a diverse group of individuals. And there's a great book by Scott Page, and it's called The Difference. Is a long title. But Scott Page is a mathematician at the University of Michigan, and he showed like a mathematical model why diversity in every field is going to help that business imperative. A diverse group of individuals, whether it's researchers, analysts, whatever you are, is always going to come up with better outcomes than a homogeneous group of individuals. The advantage to homogeneous group of individuals is that, well, we know each other, we get along quicker, and we like each other much quicker. But when you have diverse groups, once they learn how to work together, then they're going to really innovate. And that product, whatever that product is going to have a great application more broadly, right? You think about research in medicine, how was that always conducted? You had white men doing research on white men, coming up with a cure for hypertension, and then you take that pill and you give it to a Korean woman. I mean, just think about that. That doesn't make any sense, right? And so how do we expand and improve our business imperative by having diversity? And so that's why, and in healthcare, it's a matter of life and death, right? In some industries, maybe not so much so, but in healthcare, we have seen these health disparities that have been perpetuated by the lack of diversity in the healthcare field.
So speaking of healthcare disparities, right? It shouldn't be this way, but it is, and explain why. That your zip code actually has much more impact on your health outcomes than your genetic code, right? Why is that? Explain why that is, the history of it, why it matters, and how we can solve it.
Right, and so zip code to a certain degree, and then who serves that zip code, additive, right? And so when you look at communities the way we serve, and one of the things that I've started to think about with communities that I serve It's so easy to sit here and talk about all the issues of East Harlem, Central Harlem, Brownsville, Brooklyn, all these communities I worked in. But I do want to mention, I think it's worth mentioning and important to mention that in these zip codes as well, there's a lot of resiliency, there's a lot of dedication, passion for these individuals, but they deal with a lot of adversity, something that many people call social determinants of health. I don't like that term. I'm a pediatrician, as Seema said. To me, words are very powerful. Just like when people told me I couldn't become a doctor, had I listened to Mr. Ambrose in my 9th grade class, I wouldn't be here today because he told me not to aspire so high, right? And so he doesn't like when I tell that story, but Mr. Ambrose, you said that. And so words are powerful. So when you tell someone in a community like ours,
that it's a social
it's a
determinant, that means it's deterministic.
It denotes
it's
an inevitability.
Yeah.
Like you have no choice.
Yeah.
This is what's going to happen.
Yeah.
So I talk about social influences, and those social influences are things like food insecurity, poverty, poor school systems, poor housing conditions, all those things that we typically associate with. And those things, greater than the healthcare itself, have a bigger impact. I'm a pediatrician. I know how to take great care of asthma in my office. Right? But once I send that kid back out into the community and they're dealing with diesel fuel emissions, they're dealing with mold that's growing because of leaky faucets, they're dealing with cockroaches, they're dealing with smoking, all those elements I can't address in my exam room, right? And so those are the things that impact health greater than the actual provision of healthcare that we provide to a greater or lesser degree in these communities.
And we need to get to solutions, and we'll come to that in a second. But these disparities have always existed. But when the pandemic hit, COVID-19 exposed this in ways that we had never even imagined. So talk a little bit about, so it's almost like a silver lining, right? There was a dual pandemic. So on the one hand, it was a pandemic caused by the coronavirus, but the other pandemic is a pandemic that is exposed, which is, let's call it what it is, racism, right? And the outcomes, how it impacts the outcomes in healthcare. Talk about why, how it exposed it, and, was that a silver lining in your opinion?
Yes, and I mean, for many of us, to your point, right? We knew it existed. We've been living with it. We've been dealing with it for a while, and many people just turned a blind eye to it. And so COVID really put it front and center, right? It sort of really exposed the things that we already knew in our community. So in that sense, it was like, and people hate to use this term because they sort of weaponize these terms against us. It was a woke moment for many people. Yeah. But for those of us who've been doing this work, like we predicted this. We knew that Black and brown communities were going to have worse outcomes of COVID because, first of all, we weren't even getting the vaccine. Yeah. You can't imagine how much work I did to get the vaccine at our health center, right? I had to convince these politicians and these elected officials that, my Doña from across the street in Taino Towers is not going to go to Javits Center to get a vaccine that she knows nothing about, with people she knows nothing about, to stand in line 3 hours outside her community. She doesn't trust them. Yeah. She trusts us. Yeah. And so that kind of thing really helped to expose what we need to do differently. And that's what I love about this space, right? It's about innovations, about doing things differently. And this methodology that departments of health have in terms of addressing health issues in communities is too at the high level. It has to be much more grassroots. You want to know what's going on in East Harlem? Ask me. I know what's going on in East Harlem. And I can tell you what my community is going to respond to versus people in Albany or in Washington. Yep.
So what are some of the challenges, but then how can we solve for them? And how can the mainstream or allies work with communities to actually improve the outcomes in healthcare?
So the challenges are always resources, right? So we run a health center in East Harlem called the Boarding Neighborhood Health Center. It's what's considered a federally qualified health center. It's a safety net. It's a place where anybody, I don't care about your national origin, I don't care about your, that's the building. Yeah. And that's our nice little building that we moved in 2014. We love it, although it has an ugly little shed across it right now because we're doing some work on the outside of the building. But it represents a place where any patient from anywhere, as a matter of fact, this refugee issue, we've probably seen somewhere 300 to 400 refugees come through our building alone. And so we take care of those individuals, but that takes a lot of resources. Again, it's not just about the medical care. We have a behavioral health team. We have an outreach team. We have nutritionists. We have all kinds of services that these individuals need, but we don't have the resources, the capital to pay for all this. every patient, as far as I'm concerned, should have a care manager. Someone navigating their way through this complicated healthcare system of ours, which I'm not sure how many of you guys have had issues with healthcare, but if you ever get a chronic disease, you're going to really understand how you have to navigate to all these ologists, right? Your nephrologist, your ophthalmologist, your podiatrist, all these different providers. And imagine if you're someone who doesn't speak the language. Imagine if you're someone who doesn't, ask questions. How do you navigate that process? And so we try to do as much of that as possible, but it's on limited resources and limited reimbursements, because the reimbursement rates right now in healthcare are just broken. This fee-for-service model that we have right now, where I only get paid when I see a patient, is a broken system. And if it's not broken, we should kill it, because it really is not the way that we need to be working on healthcare. So in those ways, we're challenged. And so the way that private industry can partner with us is to lend us resources, whether it's space, whether it's intellectual sort of ways of doing things, innovation, technology, all those different ways for us to do things a little differently than we have been accustomed to is the way that other folks can get involved.
You talked about trust, because trust is going to be a very important currency, for lack of a better word, right? In getting people to accept the who they're getting the health care from, And so talk a little bit about why it's important to have people who look like you, who know your culture, be the ones actually connecting with you on your healthcare.
And looking like you is part of it, but the culture part is more important, right? Because culturally, I think all of us understand our cultures, right? The culture is the lens by which we see this world, right? And so when you're talking about working in a community like East Harlem, and you're talking about, food and diet, dare you tell me as a Puerto Rican man that I can't eat rice and beans? We're gonna fight. Like, it's on, right? But there is something to eating rice and beans with every meal that you should be talking to me about. How do I modify that? But understanding those sort of cultural nuances and respecting them, more importantly, right? When I was a kid, one of the things that my mom used to do anytime we had a cold or we got sick was she would take Vicks Vapor Rub and rub it all over my chest. So some people have had that experience, mostly people from my team over here. But as a physician, I know that Vicks Vapor Rub is not going to cure my disease. It felt good because mom's rubbing my chest. I'm one of 7 kids. I got a lot of attention. That was good. So you vie for attention. And Vicks Vapor Rub, if nothing else, it clears your sinuses, right? But let's say my mom now goes to the doctor and realizes I'm not getting better, and she tells the doctor that, and the doctor is dismissive of that. Mrs. Aponte, that's nonsense. Why are you doing that? That's doing nothing for your child. Stop that. What you need to do is X, Y, or Z. What's my mom going to do? She's going to walk out of that office. She's going to take that prescription, throw it in the garbage can, and say, desgraciado. For those of you who means, like, how dare he? Like, really curse him out, because he was so disrespectful to her and her culture. Whereas that doctor could say, Ms. Aponte, that's great. Do that because it does no harm. But what Adam really needs is he needs these antibiotics. And you should give him these antibiotics and explain to him what to do. And if you want to continue doing the Vicks, that's okay, right? And not that everything that's done in these home remedies are not harmful, because some of them are harmful, but you have to have a respect and appreciation for that. And then you make that connection regardless of who you are, right? So you don't have to be a Latino or Latinx to serve a Latinx population. Now, it helps when you come to the room and say, hola, mi nombre es Dr. Aponte. And that's all you can say. No hablo mucho español, pero whatever you say is fine. But the appreciation for that effort goes a long way to building a relationship and building that bond that we know all too well, even in our health center, that we're very culturally tied to our health center. It's all about those relationships.
So speaking of which, talk to us a little bit about your role as Chief Medical Officer. Tell us about this beautiful building, what work goes on there, and your team. Many of them are here.
Absolutely.
What do you do here?
What don't we do? It's an interesting job, because when you think about Chief Medical Officer in most organizations, they have a very specific role. But I do everything including windows, right? Like, we do the work that needs to get done, right? There's no my director of operations does things that, the other day, quite frankly, both her and I were cleaning up poop from in front of the building, literally. This happened yesterday, the two of us, right? Whatever needs to get done, we get it done. And that's really the whole team. But we've been in existence for 38 years. The council itself has been in existence for 56 years now. typical grassroots effort. People in the community came together and sort of talked about the things that they need. And the realization that an FQAC exists in this community. And by the way, these FQACs are designated by HRSA, the federal government, and they're located in identified areas that are underserved. And East Harlem actually has 3, which is very unusual because typically HRSA will not put a FQAC so close to each other. Mm-hmm. But what it says to you, it should say to you is that the need in East Harlem is that great. And so we provide primary preventive care services. I talk about, we do everything from womb to tomb, right? So we do prenatal care services all the way through. We try to be one-stop shopping for our patients. So we have, prenatal care, pediatrics, adult medicine. We have behavioral health services. We have nutrition services. We have a pharmacy in-house. We have care management services. Everything that our patients need, we try to do there. And then we do select specialties based upon the needs of our community. So we have high rates of cardiovascular disease, hypertension. So we have podiatrists. We have an optometrist. We had a cardiologist up until recently as well. And then we navigate them to other places that need care within our partners like Metropolitan, Mount Sinai Hospital, Harlem Hospital, Lenox Hill Hospital. And so my role is to oversee all the clinical work there. We're really proud of the quality of the work that we do because I think many places look at a place like ours and like, oh, how good a care are you going to get in that place? You get great care where we go. And I will put my quality scores up against anybody. As a matter of fact, my director of quality is here who drives us every single day. The other day she had a dream about numbers chasing her in terms of all the stats that she's looking at as far as quality. That's how she takes this to bed with her, right? And we do a lot of work on the quality. So you get great care, you get compassionate care, we hold their hands. Despite that, we've taught our staff that many of the patients who come into our facility could be very challenging, right? They'll curse you out. Like straight up, they'll curse you out. Mm-hmm. And what we've taught our staff is that most of that time, it's not about us.
Yeah, it's an internal frustration.
It's about where they're living every single day, right? Yeah. You have a single mom with 5 kids, raising them by themselves in a housing development across the street where they're selling drugs right outside the house, where there's garbage all over the place, where she's afraid to send them to school. And then you have her come to our health center. And sometimes we don't get it right, and we make her wait 15, 20 minutes for an appointment, and they get upset. Yeah. And they sort of, we're just a kind of outlet for that.
An outlet, yeah.
And we've done a lot of work teaching our staff about that trauma that people experience and how.
And to be patient.
Right, and how that's not really us.
Yeah. It's interesting because kudos, first of all, to you and to the entire team and, to the center, to the health center. How can we replicate this? In 2 ways, right? First of all, we're not far along with cloning, but how do we clone you, Dr. Aponte? Maybe we can't do it literally, but figuratively, which leads me to a question on mentoring in medicine, because, we want to talk about, how do we have more minority physicians, doctors who don't leave to the suburbs, who come back to the community? That's one type of replication. The other type of replication is, this almost seems like a bit of a one-stop shop comprehensive center, right? Because otherwise, any patient's journey these days is a maze. You go from one place to another, you don't know where you're going, you need a bit of a one-stop shop, and you've done that here. Mm-hmm. So how do you replicate both? Because you need to be able to scale, Absolutely. Right, to make a difference.
Right. So thank you for bringing up the topic. So part of my other hat is I sit on the board, a chair board for an organization called, non-for-profit called Mentoring in Medicine. And our goal is to get more Black and brown kids into the STEM fields, point blank, that's it. So we do a pipeline, and we call it the K through 16 pipeline because we start working with kids very young. And what we try to do is really, if nothing else, inspire kids that to dream big is free, right? And show them that they can do this work as well as I did, right? There was nothing amazing about me as far as, I was a smart student, but more importantly, I was dedicated. I was passionate. I had a dream. I had a focus. And when you tell kids that when you put all those things together and you make sacrifices, your dreams can come true, and they will come true. And that's not always evident in communities like ours. And so through this non-for-profit, we work with students at all ages who are interested in one of the STEM fields, although we have a big focus on getting them into medical school. Matter of fact, since our inception, we've gotten 500 students into medical school through our programmings. So that's a big accomplishment for us, small non-for-profit as we are. Dr. Lynn Holden, I gotta give you a shout out because she's the CEO there. And what we're trying to do is providing that kind of guidance and that nurturing. And all they need is that little wind behind their sails. I was telling Seema, bringing my students just into this building and seeing these labs and seeing how you do things here is inspirational for them because they don't get to witness things like this in the community. And something as simple as that, you know, for those of you who have labs in this building, Connie, where are you? Connie, I already met Connie earlier today. I was like, Connie, you want to take some students on? Let's talk about that, right? Because bringing a student to that lab not only helps Connie, right, because they're free labor most of the time, but she's also planting a seed. She's helping someone who either will become a researcher or who may become a physician. Because getting into medical school, there's a young man I met earlier who's applying. He knows this all too well. You have to have really all those sort of experiences. And little things like that. Another sort of Rayism, small things done well, right? Let's do these little things. It doesn't have to be astronomical, but these small touch points are very inspirational to these kids. And so that's why we're really happy to be here today and think about ways that we can work together.
Yeah, I can't wait till the students come here.
Oh yeah, they're going to come in.
I want to see their faces light up and, you know, be inspired. Yeah.
And as far as these health centers, I mean, these health centers exist. We're not the only FQHC. There's a lot of them doing it. But I want to break this model, actually, because I like the model of all-inclusive, doing as much as you can. But I don't like the way that we're set up in terms of how we can generate revenue. We rely on grants or seeing patients. Grants or seeing patients. And that's not the way that we're going to sustain this model because, as we all know, we spend way too much money in healthcare and we don't have the outcomes that we have. We have to use a lot more innovation in terms of how we can, you know, sort of generate revenue because, you know what, we're a business, no margin, no mission. We have to make money to keep our doors open, but we can do it in a way that, you know, there's a lot more people involved in helping us to do the work that we need to do, like our insurance companies, for example, right? How can they work with us to do something in terms of decreasing cost of care, which we can do because if we can manage care of patients and we can navigate them, I can keep them out of the emergency room. I can keep them from being admitted. I can make sure that they're adhering to their medications, right? I can get them to all their specialists, but I don't have the people to navigate them. So give me the funding to do that, and I'll decrease the total cost of care, and you're gonna save money as an insurance company. And what I want you to do with that savings, I want you to share with me. It's called value-based contracting. It's nothing new. But we need to be in that business, and FQACs have a hard time getting into that business the way that we're structured.
Absolutely, you know, great call to action for the future, right? And so because you got to innovate not just healthcare and breakthroughs and medicine, but you got to innovate the business model as well. And so that's what you're talking about. Last question from me, and then we're going to open it up to the audience, both here and also I know we have a whole bunch of people on the webcast as well. So, you know, one of the great sayings goes, if you can see it, you can be it. The importance of role models, right? You can see somebody like you who's a CEO, who's a doctor, who is a, you know, healthcare professional, physician, scientist, then you know that you can be there as a young professional, right? Talk to me about the importance of role models and, you know, how do you accomplish that in your community?
And that's so true, right? Because as a kid, I was fortunate to be in a program as a high school student. Because I was hungry. I applied for everything in the world, and I got into a program that was called Bridge to Medicine, where I spent half my senior year in high school, and then the other half at college, actually taking college courses through this program. And every doctor that came to talk to us, and no offense, was a white physician who was the son, the nephew, the cousin of another physician who lived in Long Island. And I was like, what do you know about growing up in the hood? Like, what do you know about my existence? And so I freely share my story to students, ups and downs, because I'll tell you about the D I got in physics, as well as the D I got in medical school, the MD, right? And so, you know, I share these accomplishments to show these students that this is tangible. It's not how you fall, it's how you recover. We will all fall. And then we want to be there to help pick you up as well. And when they see that and they feel like, yo, this dude is real. He's like one of us. Then they feel they can achieve that. And so we have to be able to get in front of these kids, talk to tell stories, be very raw with the stories as well, because I like to be very honest. I keep it 100, as we say, when we talk to these kids, because they need to know the reality of it. Don't sugarcoat it. And that is inspirational. And we try to do that as much as possible with our mentoring program. We bring doctors who've been working with us for years and give them these kind of forums to ask questions.
Right. So let's open it up to the audience, see if they have questions. I'm sure they do. Yes.
I'm Steph Davis, biochemist and founder of Healthy. Very good point about medicine not being personalized. I think that's a major problem. They're not chemically personalized. The blood pressure medicines in one area may not work on another population. I'm particularly talking about some Black Americans, diabetic problems. A lot of the drugs have chemically side effects, bad interactions, and synthetics. So that was a good point. There needs to be more research funding for developing better drugs that are more diversified, work better in different populations, different age groups, because one compound does not fit everybody. I mean, that was a good point.
Yeah. I mean, that was very evident when we had the first treatments for hepatitis C. The first drugs that came out for hepatitis C treatment back in, I think it was about 2006, 7, 8. I forgot the name of the drugs, but they were found to be very successful in the white population. When we brought them into East Harlem and we started treating the Black population, we started to see really negative effects, so much so that they stopped using those medications in that community. And one thing about when we talk about the other point kind of related to what you're saying is that it is not treating everyone the same. When we talk about diversity, when we talk about equity, it's not treating everyone the same. Actually, that's the problem, right? When I used
There needs to be more chemical diversity as
Right.
far as the
Yeah.
products being manufactured. When you mentioned the profit motive, medicine in one area is not the same in medicine in another area, as I've noticed. I was setting up in the process of setting up a division in DC. I mentioned about why not develop compounds and new therapies that would decrease the functionality or the need for so many amputations.
Right.
And nobody wanted to talk about that. I also have a background in microsurgery. So like there's a definite problem. You go to certain areas, Baltimore, DC, so many people with amputations in their arms, their hands. I mean, a new way of treating cardiovascular disorders could decrease that.
Right.
Yeah, definitely. Let's see if we have other questions here in the audience. Anyone else? Gabby? Oh, okay.
Hi, I'm Mark. I'd just like to know about how you, in your community, have been able to improve health literacy. I think that's one of the big problems causing these health inequities, not just within the poorer communities. Actually, in general, you could see until people really experience it in their lives, they really don't know anything about health. But personally, in your practice, in your work, in your line, how have you guys been able to increase health literacy or address this?
Yeah, it's a great question, and I'm glad you framed it that way, because health literacy does not impact, it doesn't matter what your educational level is, right? So health literacy doesn't mean that, oh, I'm a college student, that means I'm more health literate. That's nonsense. And it actually is the one thing, when you look at sort of all the impacts on health outcomes, health literacy has the greatest impact across the board, regardless of your sort of educational status. And so, we try to simplify everything that we do. I don't give someone antibiotics and say, take 1 teaspoon, 3 times a day for 7 days, right? Well, what's a teaspoon, right? And this is actually a real story, right? So mom has a kid, I'm a pediatrician, otitis media, right? Biggest ear infection, some of you have experienced it, right? The treatment of choice for that is amoxicillin. It's a liquid. So you tell the mom, okay, so take this teaspoon, give it to your child 3 times a day. The mom goes home, takes a teaspoon, and pours the liquid in the ear. So people laugh. I was like, but you know what? That makes sense. That's a liquid. That's where the infection is. Why wouldn't I put it in the ear? Right? Now, if she took a pill and started shoving it down the kid's ear, then that's a different issue, right? But we have to be very concrete. We have something called teach back, where when we tell someone what to do, how would you explain to your husband, to your wife, to your significant other, how to give this medication to your child, your loved one, whatever. So teach back is one way of addressing health literacy, making sure that we use simplified term. In medicine, we have so many acronyms and so many abbreviations. We've eliminated all those acronyms and abbreviations. We have to be very careful with things as simple as, a word. You take a word like once a day. Does anybody know how to spell once in Spanish? It's spelled the same way as once. So now you give this to a Spanish-speaking patient, they see once a day, they take 11 times, right? Is that concrete that we have to get when it comes down to giving instructions for every single thing, and then make sure that the patient tells you back what to do. And then all our pamphlets and brochures and everything like that, we really try to keep it at a level where, you know, patients can really understand what we're trying to say. But it's a continuous process with patients, and so I'm not sure that we'll ever correct it, but we always have to address it in every encounter, regardless of what that patient's, you know, educational level might be.
And as a pediatrician, you know, there was phenomenon which, you know, involved a lot of health literacy training to teach people to say, just because a child is like weighs half of you,
Right.
doesn't mean you take the pill that you would take.
Absolutely not.
Break it into two.
Yes.
And give it to the child.
Right.
Because a pediatric dose is very different than.
It's very weight dependent, absolutely.
Weight
and they're not little adults.
Yeah, they're not little adults, yes.
They're physiologically different than adults.
Than adults, yes.
And until they get to that stage, it's very important. So all those things I think
Things are.
sort of have to address.
I think there was two questions over there, yeah.
Hi, Dr. Aponte. I'm Steve Sally. Thanks so much for your talk today. I'm curious, as a fairly small organization, what are the most helpful partnerships for you to have, whether it's with other health systems, with government, with technology? What's most helpful to you in serving your community?
So all the above, but most importantly is sustained support, not this one and done kind of thing. Oh, we're going to do a little project with you and then you're gone, right? And that's the way they've done research in our communities for years. People come in, they get the research, then they leave with the research, right? And so we need relationships that really evolve over time, and they need to be agile because, you know what, it's not a linear direction in terms of the types of things that we do, because sometimes we don't have the bandwidth to take this forward, but we have the ambition to do so. And so patience and sustainability, you know, stick-to-itness, stick with us for a while and really help us to navigate some of the challenges that we navigate, because, you know, just addressing one simple issue, while it may be nice, it doesn't solve the bigger problem for us. So we need longer partnerships.
Thank you.
Hello, I'm Gabby. I'm on Cure's team, and thank you so much for doing this talk. It's really amazing and inspirational.
Thank you.
I loved how Seema opened it with a personal story of yours. So I'm wondering, what is inspiring you? Like, what is the story that you could share with us that like makes you want to do it all over again? Because I'm assuming this is a very challenging job.
Yeah.
And then on the other hand, it's like, what is the biggest frustration in this type of work that you're doing?
So we look for inspiration. We do something called a huddle every morning, and we talk about what was the day like the day before, right? And we had a patient, and I'm looking at my teammate because they need to help me out here. But there was a patient who came in from Brazil who was newly diagnosed with HIV, didn't know anything, and found us, right? Found us, and this person now had to deal with this new diagnosis of HIV, and they're from a foreign country, didn't know how to navigate anything. And so what did my team do is, like, they got him to the pharmacy, they got him insurance, like emergency insurance, like the same day, 15 minutes or something like that, Eileen, right?
Wow.
Got him medication, and now he's linked to our health center. That's the fuel. That's the fuel in our tank every single day.
Yeah.
And so it's something as simple as that, that despite the frustrations, it makes us get up in the morning and say, you know what, let's do it all again, right? You know, frustrations are more bureaucratic, systemic frustrations, right? We want to do things, we want to be agile, we want to do things differently. We're highly, highly regulated. Like, you don't know how many regulatory bodies regulate a place like ours because we get federal dollars. And so we got the feds, we got the state, we've got the city, we've got Department of Health, everyone coming in. Like, you guys all have primary care providers, right? You want a physical with your primary care provider. Let's say today is February 8th, 7th. They tell you, okay, the next appointment is in, you know, early
October,
April, whatever. You guys take that at face value. I get dinged if I make you wait 4 weeks for a primary care visit. I am required to get a patient in for a primary care visit within 4 weeks. No other place requires that, and they make that requirement upon us. Yet, you know, I'm busting at the seams. I don't have enough providers to do that. So those kinds of things where people don't understand, like, the real work that we're doing, the challenges, and set these regulatory things in place without thinking about, like, wait a minute, does that make any sense? What can we do differently around this? Not that I want people waiting 2 months for a physical exam, but let's be real, like 4 weeks is really hard, you know? So those things kind of frustrate me, where people don't get what we're doing because they're sitting in offices. And you know what, they come out, they come visit us, but the visit is not to laud us, the visit is to inspect us, right? White glove inspections. Like, you don't, like, they spend 3 days with us, and they just go through everything from, you know, the color of our toilet paper to, you know, the clinical care we provide. Like, literally, they look at every single thing because of, you know, the regulations that we fall under. And to me, that's very frustrating.
Do we have any questions from, yeah, after that, I'm just checking. No?
Hi there, thank you. This was a great talk. I really like how you bridge resiliency and compassion into your mentorship. If you had any advice for somebody looking to become an innovator in medical care or become a doctor themselves, what would you say is a big hurdle for you, and some advice that you can provide?
Yeah, see, medicine is very interesting because medicine is a very regimented, like, by the book. It didn't allow for much innovation, right? You read a textbook and that's what was the literature, right? Nowadays, what's really refreshing is that this generation of new medical students are starting to challenge things a little bit more and ask why. And now medical schools are starting to encourage medical students to ask why, and continue to ask why. And to me, that's very refreshing because, you know, diseases don't read textbooks. Right? And so while we may think diabetes is blah, 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 it may manifest in such a different way that we can't just stay so rigid in terms of what we want to do in healthcare and how we take care of it. And so I think that it's refreshing to start to see that people are starting to break down those barriers and not have this sort of regimented hierarchical system that medicine has always been. It still has a long way to go when compared to other industries, but you're starting to see some real influxes of people to think about things differently, ask questions about it, reevaluate understandings. There's one thing, for example, in the medical field that was like sort of doctrine, right? And it had to do with renal failure in African Americans. They had a factor, a correction factor. So they have something called a GFR. And they said in African Americans, the GFR could be allowed to be a little higher because they have greater muscle mass. Right? These are all these stereotypical ideas of African Americans and muscle mass, and so therefore their GFRs could be higher, but yet what you saw as a result of that was that African Americans went into chronic renal disease sooner because they weren't getting the treatments early on when they had the GFRs that were slightly elevated when compared to their white cohorts. So people started to question all those sorts of things in medicine, and now we're sort of really saying, well, you know what? That is nonsense. And so those kinds of things to me are, so ask questions, be daring, don't follow, you know, the straight line all the time. Don't be afraid to ask questions. Be respectful, but don't be afraid to push the envelope.
So I'm going to look over to the virtual audience again and say, by the way, if you have questions, you can put your questions into the chat box on your screen. So we'll give you maybe another 30 seconds if you have any questions while we take 1 or 2 more audience questions here in the room.
That means we just answered everybody's questions.
We answered everybody's question.
So,
right.
So while we think of questions and while the audience thinks about something, so places, people that are doing things, I'm going to shout out a colleague of mine, Torian, I'm sorry, Dr. Yaji, I'm sorry, Torian, I've ruined your name, but City Block under Cameron Matthews, they're doing innovative stuff in medicine. They're venture capital funded program by Google, and they created a program where they actually are taking on communities, blocks of communities, hence City Block, and they're saying, we're gonna take this community in Crown Heights or Brownsville, and we're gonna really just like flood them with healthcare. We're gonna navigate social services. We're gonna do this all in one building. And they have worked with, you know, raising venture capital so they can do what they want to do, but then working with insurance companies in that value-based contracting model that I talked about, but providing all those services. So we need more models like that, right? A colleague of mine in Buffalo, Raul Vasquez, has done some amazing work where, you know, he's taken on communities and adopted the community and said, this community is my responsibility. I'm going to do what I need to do to take care of this responsibility. I'm going to show you what I can do, and you guys are going to pay me for the work that you want me to do. That's the kind of models that I like to see more of. It's hard to do in our setting because, again, all the regulatory model, but that's what medicine needs.
Okay, last questions from me.
Okay.
So I want you to flash back. You know, we're rewinding the tape.
Okay.
So what are you going to say to young Adam, who was 6 years old, to your younger self now?
What am I going to say? Well, you're going to dress much better. But you know, you're gonna achieve that dream, and then some. Because to me, again, it was just getting across that stage and becoming a physician. I got so much gravy on my plate, you know, to be a CMO of a health center. You know, I was medical director for United Healthcare for the entire state. I mean, that's just crazy stuff for me. Like, I never thought that those are things that I can do, and I think you're going to inspire somebody.
That's
at least
great.
one person.
That's excellent. Well, thank you so much. You've inspired us this evening.
Thank you.
And this won't be the last of the conversation we'll have, because I think we want to continue to inspire the community here in New York, but also beyond. So thank you so much for joining us. Thank you for visiting Cure, and we'll see you all again next Tuesday for another Tuesday Talk. Thank you.